again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston. Dr. Loren Jones is a ear, nose, and throat surgeon, almost 15 years experience. Is that close? Because the last time I talked to you was almost 2 years ago, and it was 13 then.
Yeah, I graduated residency in 2007, so
Okay.
like 17 years. Really.
Oh, even better. We're getting there.
Getting
and
older.
all of your practice is in spearfish then, correct?
Yeah, only in spearfish.
Okay, excellent. And then I've got PA Kayla Tollefsrud with us too. Hi, Kayla. Welcome back.
Thank you.
This is the second time you've been on here with me so far. Yep. Last time we talked about sleep apnea, which is kind of what we're going to tie this into today. But if you want to go back and listen to anything that Dr. Jones did as episode 13, 18, and 25, and then you were very early on in this too.
That is early.
And then 95 was yours. So we've crossed that 100 episode threshold. And, we'll have you guys back for around, 197, 198.
There you go.
Somewhere
We'll give it
in
a
there.
minute.
Perfect. Well, really quick, doctor, we're going to talk about a procedure that's used to help people with, I want to describe it as severe sleep apnea. Would that be fair?
Not necessarily
Really?
severe.
Okay.
It can be from sort of moderate sleep apnea up to severe.
Okay.
But it's for people that don't tolerate the gold standard of therapy for sleep apnea, which is continuous positive airway pressure, CPAP.
So if you can really quickly just tell us what sleep apnea is.
Well, there's two main kinds, and Kayla can talk more to this directly since she's in sleep medicine than I am, but there's central sleep apnea, which is when your brain is having a problem, doesn't tell you that you need to breathe, and that's treated in a slightly different way with slightly different kind of machine generally. Obstructive sleep apnea is kind of what we're talking about today, and that is when your muscle tone in your throat is inadequate while you're sleeping and the airway starts to narrow, and that may make things rattle around and snore, but on a continuum of the same sort of pathophysiology, things will then close and block the airway entirely, and your chest is being told by your brain to pull air in, but there's a blockage at the throat level between above the larynx and kind of below the palate, somewhere in that range in the middle of the throat. And that stays that way until your brain says, wait, my oxygen's starting to drop, I'm not moving air, and I need to send some muscle tone back down to the muscles in the throat, open my throat up so I can begin to move air again. And the problem with sleep apnea, not only is that process hard on your heart when it messes with your cardiovascular dynamics quite a bit, but it interrupts your sleep as well, because even though you don't wake up usually when that happens, every time that happens, your brain has to arouse a little bit to send that muscle tone down and get your throat opened up, and you end up with an interruption of the stages of sleep that you need to go through to get a restful sleep.
Yeah, you're not getting into that deep REM that they say you need, correct?
Yeah.
In that area. Well, is this, Kayla, is sleep apnea really common?
It's pretty prominent.
Is it really?
Yep. Yeah, we used to think it was overweight men. Now we know that that's not necessarily the case. We see all ages, gender-wise, it's pretty even mix. Even children can have the diagnosis.
Oh, that's right. It can go all the way down to kids in some instances.
Yep.
Has it become more prevalent because of the way as we Americans live our lifestyle a little bit too than it used to be?
Yeah, so weight is definitely one of the contributing factors. Not the only factor, but it definitely does play a part. When you have a lot of weight on your neck and your chest and things, that will cause you to have more obstructive events. Like I said, obviously weight's not the only thing. A lot of it has to do with airway structure and anatomy of the throat and the mouth and things too.
Okay. So. Well, as an example, I wouldn't consider myself to be overweight, but I do have sleep apnea, and So I would be one of the instances where it might be structural then for me in that instance. Oh, that's. I thought I was built okay. Maybe not. So it can just happen, I suppose.
Yeah.
So in a lot of instances, what is basically used to help people that have I don't want to say normal sleep apnea, but less than severe sleep apnea or moderate sleep apnea? What do they use?
So as Dr. Jones had mentioned, typically our gold standard or the first treatment, the first line treatment is the PAP device. So either CPAP therapy, which is a continuous pressure, or APAP, which is the same idea as just adjusting settings. So typically those are the two options that we use for people.
And so that's the one where most people see the headgear that you have to wear, right?
Yes. So you have the mask, you have the hose, you have the machine. Yep.
Yeah, the whole thing.
Yep.
And there's ones that can cover your nose and mouth, ones that can just go over your nose like the pillows. Mm-hmm. There's ones that can go in your nose. Am I missing any?
Yeah, so there's the there's ones that have hose connections on top of the head, in front of the face, and then like you say, there's the full face ones. There's a lot of variations of full face and nasal. Over the years they've come out with several different options when it comes to mask style and things.
And I suppose it's just for comfort reasons to help people sleep, right?
Yeah, it's just, people, whatever they're comfortable with as far as style goes. Yeah.
Okay. So let's move into when it gets more serious for moderate or serious sleep apnea. There are stages that I know we talked about in the last episode when we talked sleep apnea before too. Can you kind of quickly cover like what those light, moderate, severe, what that means or how it's different?
Yeah, so when it comes to sleep apnea, there's different severities, like you mentioned. What we're looking at is the AHI, which is the apnea-hypopnea index. And so what that stands for is that's the number of times per hour that you're either stopping breathing or having these episodes where you're not breathing as well as you should be with that associated oxygen drop. And so anything above 5 episodes per hour is actually treatable. So typically 5 to, say, approximately 15 is considered to be more mild. Mm-hmm. And then 15 to approximately, 25, 30 is more moderate, and then usually anything above 30 is more severe.
Okay, so let's say we're into that severe area, and or even moderate, and you've set them up with the machines, and they just don't work. People either can't sleep with them. It's not helping that index, mm-hmm. right? There is a device that is known as the Inspire, correct?
Yes.
And that's kind of what we want to talk about today. And we talked a little bit about this, Kayla, on the sleep apnea episode that we did. And I'm so glad both of you guys are back because I did want to dive into this a little bit more. So what exactly is the Inspire procedure, Doctor?
Yeah, so it's kind of a 2-step surgical procedure. So if you meet some certain candidacy criteria, which we can brush on if wanted, but if you meet the candidacy criteria and the sleep medicine professionals and myself think that you'd look like you'd be a good person to potentially try this, that might help you, we start out with a thing called a drug-induced sleep endoscopy, which means you go to the operating room, you get IV anesthetic, only you don't have a breathing tube put mm-hmm. in because we want to look at your airway mechanics while we're mimicking natural sleep the best we can with drugs. So put you lightly to sleep just so you're barely unresponsive, and then we put a camera through your nose and look at your palate because the Inspire device stimulates the muscles of the tongue while you sleep, keeps your tongue from falling back into the throat and blocking your airway. But apneas and hypopneas from sleep apnea can happen not just at the level of the tongue, they can happen up at the level of the palate as well. So the drug-induced sleep endoscopy is to make sure that the patient is not having complete obstructions at the level of the palate, because then Inspire would not help them. We would be doing them a disservice. So we have to check that. And once we check that, if that looks favorable, which for about 80% of people that go to the point of getting that sleep endoscopy done, it's okay and they're a candidate for Inspire afterwards, then we do a separate surgery on a separate day that's a more significant operation. So that involves an incision in the neck just below your jaw on the right-hand side and finding a nerve in the neck called the hypoglossal nerve. And it's fairly intricate. We have to use magnification for it because the nerve has branches that go to muscles that push your tongue backwards and to muscles that push your tongue forward. And these are not like clear-cut branches of a tree. It's like one piece together, and you kind of have to spread longitudinally this nerve into two.
But you can find that nerve? I mean, you can see it?
It's a reasonable size. It's probably 4 millimeters across or something like that. So it's not, it's like, maybe 3/16 of an inch wide or something. Anyway, we get the electrode array, which is a little piece of silicone with electrodes in it, and wrap it around the nerve. And then the wires from those electrodes get sent under the skin. of the neck into the upper chest, like where a pacemaker would be, but on the other side. Most cardiac devices are on the left. Inspire generally goes on the right. So you have an incision in your neck and an incision in your chest. And in the chest is the device, which is about that big, and it has a battery in it and the electronics, and it also has a sensor to tell when you're breathing. And then this is about a 2 or 3 hour operation, same day surgery.
It's got a battery in it.
An 11-year battery.
Oh, wow. So have you reached a point with Inspire yet where you've had to change any?
We have not. Not here in Rapid City.
Right, okay.
Yeah, in the area.
It's been about 3 years ago that they've started doing
That's
that.
so okay, so nobody has reached that point yet to be the first one to go in and flip it out and change it for something else. Well then who is an ideal candidate for this, doctor? Who is the perfect person to have this implanted?
Well, it's really anybody that has anything from moderate to pretty severe sleep apnea.
Okay.
The number can be, that Kayla was talking about, anywhere from 15 to 100 according to the FDA. So that's vast majority of sleep apnea patients. But it's not for everybody with sleep apnea. You can't jump straight to Inspire because we know that CPAP is effective therapy if the patient can tolerate it. And the majority of patients can tolerate it. I think Kayla can maybe answer better. My understanding is around 70% of people will be
That's a pretty high number, isn't it?
be able to tolerate CPAP. And so that's where we want people to start for a few reasons. It can be more effective than Inspire because it treats not only tongue obstruction, but it also treats obstructions at the level of the palate because that positive pressure is everywhere in your airway and holds the whole thing open. So CPAP is very effective, and it doesn't have any potential risks, and it's not a big expensive surgery that you have to have. So that's why it's the first line therapy. So to get Inspire, you need to have the right kind of sleep apnea, which most people with sleep apnea do, and you need to not tolerate CPAP.
Okay.
And the not tolerating CPAP is the part that's a little gray because that's not sort of super specifically defined by the FDA or anybody else. It's really a discussion between your sleep medicine provider, your surgeon, and yourself to say, okay, have we really given this a real try to see if you can get used to using this thing? And a lot of people don't even want to go in for a sleep study because they're like, nope, no way I'm wearing that.
Right.
And so I think we do a disservice to a lot of people just by scaring them off with CPAP when they just can't kind of wrap their head around the idea of going to bed with like a ventilator strapped to their face or something.
Yeah, and it's nothing like that. I mean, even the sleep study, it's not that bad. I mean, there's a lot of wires on you when you're doing a sleep study like that for sure. And I don't know if you get the best night of sleep of your life, but you just need to get enough, right? And they're not. I mean, the equipment now, I can't imagine how those things used to be. I probably weren't super comfortable because you didn't have a lot of options, right? And now, they make it for anybody's sleep habit, I would think. But do you get some people to come in and they're trying to sell you hard on getting that Inspire put in?
Yeah, so as Dr. Jones had said, they have to have some sort of intolerance. And so as he mentioned, the intolerance is kind of a gray area. So, a lot of people, they come in and they say, I don't like my machine. I don't like the mask. And you look at their compliance report, you see that they wear it every night for 8 hours and their AHI is super well controlled. Or another one that we hear a lot of times is that they don't like to travel with it. It's cumbersome to take with them or this and that. And so, that's where, like Dr. Jones said, it's kind of that conversation. Is this a true tolerance or do they actually do pretty well with it? So it's kind of making that determination. Is this a candidate or not?
Right.
Yeah.
So I wonder if it's, it's got to be so hard for you guys as doctors to know that a device like that exists and probably think, it's been safe, it's been proven, the whole thing. We'd like to give it to you, but, just keep doing what you're doing and let's not cut into your body at this point, right?
It's a tough line to walk because I think that there's certain, you said you wear a CPAP, so do I. There's certain, even if you wear it every night and tolerate it and can sleep with it on, there's a certain amount of, I think, cost to your quality of sleep. Not as bad as untreated sleep apnea,
of course,
but fiddling around with the mask a few times a night, every time you roll over, you got to fiddle with the hose, and it can be a little bit disruptive. And so I could certainly understand people wanting to just say, hey, chuck this, and I'm going to get that other surgery, and it's a one-stop shopping, and it's simple and easy, and everything's going to be perfect. And part of the reason that that I wanted to talk today is kind of just about that.
Yeah,
I
absolutely.
think the Inspire as a company has been doing a lot of very prominent advertising and all kinds of media that is very appealing advertising, and I think I have been asking to be able to get starting to do this in Spearfish for quite a while with the company, and so we're very happy to be offering it. But we want to offer it to the right people. We don't want to just have it be the thing where we're trying to open the floodgates and just do a bunch of stuff that maybe isn't really super appropriate by the FDA's recommendations or the experts' recommendations. So it's a balance where we want to have the right conversation with people, help them understand what it really means and what the pros and cons of the options are and what it really means to truly not tolerate CPAP. And on the flip side, I would say that people, like I mentioned before, that are out there that don't have any desire to go do a sleep study, but their bed partner tells them, hey, you stop breathing all the time. Right. This is a problem. That if you're sure that you couldn't wear a CPAP and make it work, still go in and get your sleep study done. Mm-hmm. Try it for a while. It's not a life sentence. Try it for a while. Course. It might be as short as a month or two to be able to say, you know what, there's just no way this is working for me. I just have a claustrophobia thing with my face or whatever the case may be. I just can't do it. And then there's another option, beyond some of the things that we used to have, like oral appliances, and some of those kinds of things that are a little bit effective, but not as good as Inspire or CPAP.
Well, then you mentioned that it's a 2 or 3 hour surgery. Mm-hmm. It's making 2 incisions in your body.
Yeah.
Close to parts of your body that I don't want incisions to be at.
Right. The chest part is really just kind of soft tissue, muscle, and subcutaneous tissue. But in the neck, there's a lot of important stuff.
Exactly. Yeah. I mean, that's to me, that would be more of a deterrent, I guess. Because, it is. It's a great conversation to have, especially if you have sleep apnea, to consider it. But boy, there are pros and cons you have to weigh, and you got to weigh them pretty hard, right?
For sure. And I think Kayla could speak more to kind of what kind of experience people can expect afterwards, because it's not like you walk away from the surgery and then it's over. There's a lot of follow-up that happens to make sure.
Well, what's the before we get to that, what's the recovery time for something like this?
So we try to tell people to avoid heavy lifting or strenuous activity for 2 weeks.
Okay.
The incisions are covered with like a mesh and glue system so that you can shower and everything normally right away. And it's same-day surgery. You should be normal daily activities the next day, just nothing strenuous or heavy. And pain is, present but not severe by any stretch for most people with this kind of surgery. So the recovery is, it's going to cause you to modify some things for a week or two, but after that, it's not too bad at all.
Okay. Then once that's done and you're recovered, what do you have to tell them, Kayla? What's the next step?
So once the device is implanted, Dr. Jones has done the surgery and everything. The device is not actually on at the time. We give him a chance to heal and everything. And then what we do is we see him in our sleep medicine clinic. And at that time, it's been we usually give them a month or so, before they come in for the activation. So when they come in for the activation, that's when we actually turn the device on. And so at that point in time, we get those correct voltage settings. Everyone's going to need some different voltage to move that tongue out of the airway and things. So we'll determine the voltage settings. The remote is a big thing that everyone talks about, is what they see. So we have to show them how to use the remote. That's how you turn the device on, turn the device off. You can pause it in the middle of the night.
So you don't keep it on like during the day. You turn it off.
It's only on when you're sleeping.
Okay.
So obviously during the day if you're napping or something, but only when you're sleeping. Yes, because it's moving the tongue. So if the device is on and you're awake, you're not going to be able to eat or drink or talk or.
Now I want one just to try to be on the radio with it to see what happens when it's turned on.
Some good comedy.
Yeah, it would be.
So anyways, they come in for the activation. Like I said, we find the appropriate settings, educate them on the remote and how to kind of use everything. And then we always tell people, so the tongue is a muscle basically. And so we don't start them at like the highest stimulus. We start them kind of at the lowest. And then we advise them that over time, as they tolerate it on their little remote, they're actually able to increase the stimulus. So we tell them, each week, if you're tolerating it, to kind of go up on the stimulus stimulus and see how you're feeling. We give them a little sheet. They can mark how they're feeling with the stimulus. Do they notice an improvement in their daytime sleepiness? Are they sleeping fine? And then once they kind of reach that top where the threshold starts or the voltage starts to bother them, then we kind of have them leave it there. And then following the activation, obviously, then they're good to start using it at night and increasing as tolerated. And then we do follow up several times with them after it's been activated too.
Do you have issues where people have it and then can't tolerate it and then want it out? Has that ever been a thing?
So I don't know that so personally I haven't had that situation. I think there have been instances. I don't know if you necessarily take it out or you would just leave it. But sometimes if they're having trouble tolerating the voltage or something, we can either adjust the stimulus or we can actually change the electrode configuration too. There's different configurations that we can do on the hypoglossal nerve. So if they're struggling with it, there's some changes and things that we can adjust to make it more comfortable.
Okay. And you said this has only been around about 3 years, 4 years?
Oh, here, I think that
or just
it started
here?
in Rapid City 3 years ago, but I think they've been 8 or 9 years now.
Yeah, I think 2014
was the first time they did it. It really is a pretty unbelievable little piece of equipment that they can throw in your body to do something like that. And, how they can manipulate your tongue to do, to get out of the way.
It's not subtle when
really
during the surgery before we close the incisions, there's a rep from the company there, and they have a little probe that activates the device, and we watch the person's tongue through the drapes, through the clear drapes, to make sure that it's pushing the tongue out and not pulling it back at all the voltages we test. And so, it pushes the tongue out.
So that's what happens. The tongue actually... No kidding. It comes all the way out of you like you're sticking your tongue out of somebody.
When we're testing it in the OR, we have a pretty high drive level. But in a patient that's asleep, if you're looking in their airway with a camera while you turn it on in the clinic, it definitely, it moves the tongue forward and it opens the airway nicely. But that's the balance that Kayla and the reps work with on the activation is finding that level that controls their apnea as well as possible, but still tolerable. That it's not annoying them and making them stay awake. And the device, when you turn it on, it's a variable delay, so it can let you fall asleep before it activates. Usually around half an hour or 45 minutes, maybe something like that, before it turns on after you've laid down and closed your eyes and clicked it on. And then, like she said, you can pause it if you have to get up and use the bathroom or something like that. And you guys generally do a sleep study 3 months post-op with the device activated?
Yep. So as long as the patient is tolerating things and everything is going well, we usually try 3 months after the activation. We do a fine-tuned sleep study is what it's called. The reason we do that fine-tune is because in comparison to like a CPAP, you get a little download and it tells what the nightly AHI is. So this device doesn't necessarily, as of yet anyways, have the option to give us their nightly AHIs. And so we do the fine-tuned PSG to make sure the device is actually working adequately. So we want to make sure that their events per hour, that apneic episodes, they are decreasing with the device, that the current voltage is working adequately. And then based on that sleep study, we can tell the patient, well, you need to go up a little bit on the voltage, or you can come down, or so on and so forth.
What's a normal index for people when they're sleeping?
AHI, you mean?
Yeah.
So anything less than 5 is considered to be normal. So that means you don't have sleep apnea.
And when you're saying less than 5 what?
So that's either the apneas or hypopneas per hour.
Okay.
Yep.
So
times per hour your breathing is disrupted.
I see. But so it must happen to everybody then, doesn't it?
A little bit.
More or less.
Yeah, that's why the threshold is kind of arbitrarily set at 5.
Okay. Is there any question that either one of you want people to come in and ask you that you guys don't feel like they ask enough? Do you guys have any questions like that where, I guess I don't know what that could be, but it always seems like by the time you're done talking with people, like, oh, I wish they would have, or either I didn't mention, or I wish they would have asked this thing. Is there anything like that you guys can think of off the top of your head, I guess? I know it's kind of a question out of the blue. Should have given you more time to think about.
No. For me, back to the part of the bottom line of what I've been trying to make the point of being here is that the question I might ask is like, okay, well, what works better, a CPAP or Inspire? And I think Kayla could tell you that generally the AHI is going to be better controlled. to a lower number, to a number that's within the range of normal, more often with a CPAP that a patient can wear and tolerate than with Inspire, just because it's treating more areas that can cause obstruction.
Got it.
But, so I'd like patients to think about that and say, okay, well, there's a reason to think that maybe working to actually try to give it a real effort to try to tolerate CPAP is worthwhile. But on the other hand, patients that can't or just can't even wrap their head around it to start, like a solution that's 99% effective that you can't use is worse than a solution that's 85% effective that you can use.
Right.
So that's the balancing act we're trying to walk with our team between sleep medicine and myself. And
I suppose it is just convincing people to just try it. I mean, everything takes a minute to get used to. Don't give up after a week when you don't feel like you're sleeping well, or you're constantly adjusting it, or the air's coming out of there and your wife's like, could you please put that back so I don't hear it, sort of a deal, right? Well, I want to thank both of you guys for coming in and talking about this for sure. And ask the questions. I think that's the most important thing with this, right? But, just from personal experience, give it a try. Give it a try.
For sure.
CPAP, for sure.
If somebody tells you that you're having a problem breathing when you're sleeping, come see Kayla, or you can come see somebody like me or to see your primary and get the process started and know that there's options. If you're like CPAP scares you to death, just know that work your way through the process. There's other options that are good and effective options. They take some work, but are worthwhile, and we're happy to.
Do you think we'll get to a point where an implant like that can do everything?
Like monitoring the HI?
Doing the tongue and the palate, and fixing.
Oh, I wouldn't be surprised if there's a point where they can try to look for that. The innervation of the palate is a little more complex than the tongue, so that'd be probably the biggest limiting factor there, would be defining how you're going to go after anatomy of a physical nerve that you have to dissect down on and put an electrode array on to stimulate palate muscles appropriapely. So,
sure.
But I'm sure that it's going to be worked on,
Well, and then the pill will be when?
The pill?
We can just take the pill and be done.
Yeah.
There's already been talk about it.
It's great talking with you guys again, of course. Anytime you want to come in and talk about sleep, let's do it, because these are it's so, sleeping in general is just interesting. It's something we all have to do. Yeah. And you want to make sure it's you're getting the best one you can.
It's hugely important to your quality of life.
Absolutely. Kayla Tollefsrud, the PA. Are you in Spearfish too, though, right, Kayla?
Yes, so I do some outreach in Spearfish. Okay. My primary office is here in Rapids.
Oh, excellent. All right. Yep. And then, of course, Dr. Loren Jones. Thank you guys both for coming in and talking again. I appreciate it.